Did you know the number of adults worldwide with diabetes is projected to, well, more than double in just a few decades?
Wow.
Just think about that for a second. That kind of massive increase, it isn't just a statistic, right? It has a real knock-on effect across um, all areas of health, especially something as widespread as vascular disease.
Okay.
Okay, let's unpack this because understanding these shifts is, well, it's crucial.
Absolutely. Today, we're taking a deep dive into the international and ethnic trends in vascular disease.
Okay.
And our main sources for this, they come from chapters in Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's a really, really comprehensive resource in this field.
Right, Rutherford's is definitely a cornerstone. Now, why should this grab your attention? Well, vascular disease, it touches practically everyone's lives in some way, doesn't it?
Mm.
By understanding how these conditions differ across the globe and, within our own diverse communities here in the U.S., we gain some really important insights. Insights into this major global health challenge and how it might affect you or maybe people you know.
Yeah.
Our goal today is really to pull out the most vital information from these detailed chapters without getting completely bogged down in the super technical stuff.
Precisely. Our mission, if you like, is to explore these key international and ethnic trends in vascular disease,
Identify the main risk factors that are driving these patterns, and talk about the strategies being developed, both globally and nationally, to try and tackle these really significant health issues.
Okay, sounds good.
So let's start with the big picture then, international trends.
Yeah.
When we look at the world stage, what's the overall situation with vascular disease? Well, in broad terms, atherosclerosis is the leading cause globally. We're talking conditions like ischemic heart disease that affects blood flow to the heart.
Stroke, which impacts the brain, of course, and peripheral arterial disease, PAD, affecting vessels outside the heart and brain.
Got it.
And the increasing burden, the impact of these diseases, it's mainly down to rising trends in key risk factors, the big ones being smoking and diabetes.
That makes sense.
Yeah.
I mean, those are two huge global health issues just on their own. So let's zoom in on tobacco use first. What are some of the major international trends we're seeing there?
Okay, globally, we're still looking at over 1 billion smokers. 1 billion.
Wow.
The positive news, though, is that the overall percentage of people using tobacco daily has decreased over the last 30 years or so.
Okay, that's something.
But this decline, it isn't happening evenly, not at all.
Hmm.
There are significant differences based on gender and, where people live. For instance, men smoke more than women in literally every region around the world.
Every single one. So where's the biggest difference then between men and women smokers?
The largest gap, that's in the Western Pacific region. Europe actually shows the smallest difference.
Interesting.
And regionally, Southeast Asia has the highest percentage of smokers overall, nearly 50%. That's huge.
Half the population almost.
Yeah. Followed by Europe, the Western Pacific, Eastern Mediterranean, the Americas, and then Africa has the lowest rates.
Okay.
What's a really interesting point, though, is that back in the late 20th century, smoking actually became more common in some developing areas, like Latin America, the Eastern Mediterranean, Southeast Asia, too.
But we've seen that trend reverse more recently, haven't we? I mean, I feel like we hear about declines more often now.
Yes, thankfully. In the first couple of decades of the 21st century, there's been a definite global move towards less tobacco use.
Okay.
The proportion of the world's population that smokes went down from about maybe a third in 2000 to around a quarter by 2020.
That's a decent drop.
It is. And this reduction, it's been seen in both men and women and across all regions. Southeast Asia actually showed the most significant progress, especially among women.
Well, that's definitely a step in the right direction. But what's the real human cost? I mean, all this tobacco use, what's the impact?
Oh, it's immense. More than 8 million people die every year just from tobacco use and exposure to secondhand smoke.
8 million.
And smoking, it's estimated to be responsible for nearly 10% of all cardiovascular deaths globally.
10% just from smoking.
Yeah. And it's noteworthy that the percentage of heart-related deaths linked to smoking, it varies quite a bit by region. North America has the highest at 22%.
Wow, over a fifth.
Followed by Eastern Europe at 17%, Western Europe 13%, and Southeast Asia around that 10% mark.
Okay. And how does smoking directly, increase the risk of actually developing these vascular diseases?
Well, the evidence is pretty compelling. For men who are current smokers, their risk of dying from ischemic heart disease and stroke is about 1.6 times higher compared to guys who've never smoked.
Okay, significant.
But for women who smoke, the risks are even more pronounced. They
Uh,
face 3 times the risk of death from ischemic heart disease and stroke,
Free to
and a staggering 6 times increased risk of dying from an aortic aneurysm compared to women who've never smoked.
6 times. Those are really, really powerful numbers. So looking ahead then, which countries are likely to face the biggest health challenges related to smoking? Where should we be most concerned?
Well, the countries that currently have the highest rates of smoking and where people who smoke tend to smoke a lot, more than 20 cigarettes a day.
Right, heavy smokers.
Exactly. Those are the ones likely to see the most significant health consequences down the line. This includes places like China, Greece, Ireland, Italy, Japan, Kuwait, Korea, the Philippines, Uruguay, Switzerland, and Russia. Quite a list.
Yeah, a diverse list too. Okay, let's shift gears a bit and talk about the other major driver you mentioned, diabetes. We started with that striking projection of it doubling. What are the key international trends there?
Yeah, the global diabetes epidemic is, well, it's expanding very rapidly, particularly in places like India and China, largely due to adopting lifestyles more common in Western countries.
The Western lifestyle effect.
Exactly. And projections suggest that the number of adults worldwide with diabetes will likely double between 2000 and 2030.
That initial stat you mentioned.
Yes, and this is happening because, well, more people are surviving communicable diseases, which is good.
Right.
Food is often more abundant, maybe not always the healthiest food, and many people are just less physically active than they used to be.
It's a perfect storm, almost. That paints a picture of a really significant shift in global health. What are the current numbers, roughly, and what are they expected to become?
Okay, so the International Diabetes Federation estimate around 415 million people globally had diabetes back in 2015.
415 million.
And this number is expected to rise sharply to get this 642 million by 2040.
Whoa, over 600 million.
Yeah. By 2017, it was already estimated that about 10% of adults over 25 worldwide were living with diabetes.
1 in 10 adults globally. And are there big regional differences in how common diabetes is?
Oh, absolutely. The highest rates were found in the Eastern Mediterranean and the Americas. Africa and the Western Pacific had the lowest rates.
Okay.
Interestingly, population growth and the simple fact that populations are aging accounted for a large majority, something like 70% of the new diabetes cases seen between 1980 and 2008.
So demographics play a huge role.
A huge role. And looking forward, the Eastern Mediterranean and Africa are the regions projected to have the fastest growth in the number of people with diabetes.
Okay, so that's where the acceleration is expected to be highest. What about the number of deaths linked to diabetes on a global scale?
Well, in 2017 alone, nearly 1.4 million deaths around the world were attributed directly to diabetes.
Almost 1.5 million in 1 year.
And large studies have shown pretty consistently that having diabetes basically doubles a person's risk of dying from vascular causes.
Doubles it.
So, as we see these regions experiencing the biggest increases in diabetes prevalence, we can unfortunately expect to see a corresponding rise in illness and death related to blood vessel diseases as those populations age. It's a direct link.
Right. It's almost inevitable, sadly. So with these major risk factors, tobacco and diabetes firmly in mind, let's turn our attention to specific types of vascular disease and their global trends, maybe starting with ischemic heart disease, IHD.
Okay, IHD. Worldwide prevalence is somewhere around 5% to 8%. Now, when we look at trends, specifically the incidence of new heart attacks, AMI, and the prevalence of angina or ischemic heart failure,
Right.
we actually saw a decrease globally between 1990 and 2010 after you adjust for age differences in populations.
Okay, so some progress there.
Yes, the biggest improvements were seen in Australasia, Western and Central Europe, and the high-income areas of North America. However, Eastern Europe was a bit of an exception. They actually showed an increase in the number of new heart attack cases during that period.
Huh, that's a notable regional difference. What about deaths from IHD? Where are those types?
In 2017, the highest death rates from IHD were definitely in Eastern and Central Europe. Their rates were more than 10 times higher than those in Eastern and Western Sub-Saharan Africa, which had the lowest rates.
10 times higher. Massive difference.
Huge. However, there's been a recent positive shift in Eastern Europe. Even though the number of people with IHD has been increasing, the actual death rate from it has been steadily decreasing in the last decade or so.
Oh, that's interesting. Why is that?
It's likely because of better treatment options becoming available and being implemented more widely, better management.
Makes sense. Okay, moving on to cerebrovascular disease, stroke.
Yeah.
What are the global trends there?
Right, stroke. The WHO estimated about 11.9 million strokes worldwide in 2017.
Nearly 12 million.
Yeah. The highest numbers were occurring in the Western Pacific, East Asia, and Europe. Now, globally, the rate of new strokes, again, adjusted for age, it decreased by about 12% in high-income countries between 1990 and 2010.
Okay. Good news for high-income countries.
But perhaps surprisingly, it increased by the same percentage, 12%, in low and middle-income countries, the LMICs.
Wow, so a widening gap there. What's the overall impact of stroke around the world? How serious is it?
It's incredibly serious. Stroke is the second leading cause of death globally.
Second only to.
Ischemic heart disease.
Got it.
And while the total number of deaths and the disability burden measured in dailies or disability-adjusted life years loss,
Right.
while those have actually increased over the past 2 decades, particularly in LMICs, the death rate from stroke, when adjusted for age, has significantly decreased worldwide.
How did that happen?
It seems to be largely because of a really substantial 36% drop in mortality among people older than 75.
Ah, so better survival in older populations.
Exactly. Better prevention strategies and definitely improved medical care, particularly in high-income countries, are likely the main reasons for these positive trends. And, coming back to smoking, even modest reductions in tobacco use in countries with really high stroke mortality rates like China, Russia, India, that could prevent millions of deaths. It really could.
Yeah, the potential impact is just huge. Okay, let's turn our attention now to peripheral arterial disease, PAD. What does the global picture look like for this condition, the one affecting blood flow in the limbs?
Okay, PAD. Globally, over 200 million people are living with it.
200 million.
And a significant majority, something like 2/3, are in low and middle income countries.
Right, disproportionately affecting LMICs.
Definitely. And in the past 10 years or so, the number of people with PAD has increased in both high-income countries by about 17% and LMICs by a whopping 36%.
36% increase in LMICs. That's rapid growth.
It is. The highest rates of new PAD cases in 2017 were seen in the Western Pacific and Southeast Asia, which are largely LMICs, while the Eastern Mediterranean and Africa had the lowest numbers.
And what's driving this increase in how common PA is becoming?
Well, the increase is most noticeable in older adults. This suggests that the global prevalence of PAD will likely continue to rise pretty rapidly. Why? Because of the world's aging population, and of course, the increasing prevalence of those key risk factors for atherosclerosis we talked about, especially smoking and diabetes.
Right, the aging population plus those risk factors. How does PT compare to IHD and stroke when it comes to, how deadly it is?
Interestingly, PAD is generally associated with a lower risk of death compared to IHD and stroke. It only accounts for maybe 1% to 2% of cardiovascular deaths globally each year.
Okay, much lower mortality, relatively speaking.
Relatively, yes. However, the high-income regions of Europe and the Americas have consistently had the highest regional death rates from PAD.
So higher prevalence in LMICs, but higher mortality rates from it in HICs. That seems counterintuitive.
It might seem so, but it could reflect differences in perhaps the severity of PAD when diagnosed, coexisting conditions, or maybe even how deaths are classified in different regions. It's complex.
Okay. What are the implications of these PA trends, particularly in lower-income countries where it's rising so fast?
Well, these trends present a really significant public health challenge in LMICs. The rapid increase puts a massive strain on already limited healthcare resources.
I can imagine.
Furthermore, in many of these regions, people rely heavily on walking for their daily activities, transportation, work. So PAD can severely impact their quality of life and ability to function.
Yeah, basic mobility is threatened.
Exactly. And the limited availability of advanced healthcare, like revascularization procedures, may also lead to a substantial rise in the number of limb amputations in the coming years in these areas. That's a major concern.
Yeah, a really devastating outcome. Finally, in this global section, let's discuss aortic aneurysm, that weakening and bulging of the aorta. What global trends are we seeing there?
Okay, aortic aneurysm. We saw a pretty consistent rise in both the occurrence and death rates from both types, thoracic in the chest and abdominal, in many high-income countries during the latter part of the 20th century. By the year 2000, it was estimated about 5% of the population in some of these areas had one.
Okay. What about more recently, say 1990 to 2010?
During that period, the highest global prevalence was found in Australasia and high-income North American regions, although, interestingly, they've seen a bit of a decrease more recently.
Oh, okay. So it peaked in started coming down in some places.
Seems like it. On the other hand, regions like Oceania, tropical Latin America, high-income Asia-Pacific countries, Central Asia, South Asia, and Sub-Saharan Africa all showed an increase in how common aortic aneurysms were during that time.
So a mixed picture globally. While they might be becoming less common in some high-income areas, what's happening with the number of deaths overall?
This is the concerning part. Despite an overall global decrease in how common aortic aneurysms are, the prevalence,
Right.
the rates of death from them actually increased worldwide between 1990 and 2010.
Increased mortality despite decreasing prevalence overall. How does that work?
It suggests that while we might be preventing some aneurysms from forming, perhaps through better risk factor control in some areas, the ones that do form might be more lethal, or maybe diagnosis and treatment aren't keeping pace globally, especially with rupture. The highest death rates have consistently been in Australasia and Western Europe over the past few decades.
Okay.
However, some high-income countries have seen a decline in mortality more recently.
And why is that?
It's likely due to a combination of things. Widespread efforts to reduce tobacco use, which is a major risk factor,
Right.
and also the implementation of targeted screening programs, especially for abdominal aortic aneurysm in older men, which helps catch them early before they rupture.
Screening makes a difference. It sounds like there's a lot of effort underway, though, to address these global trends across the board. What are some of the key global strategies being used to try and reduce the burden of vascular disease?
Absolutely. Public health measures that focus on managing the big risk factors: high blood pressure, high cholesterol, diabetes, and especially reducing smoking. These are effective across the board. For IHD, stroke, PAD, aortic aneurysm, tackling the roots helps everything.
Makes sense. A common pathway.
Exactly. And there are highly effective and, importantly, affordable ways to reduce tobacco use. Things like increasing the price of tobacco products through taxes.
Yeah, price hikes work?
They do. Implementing policies that make workplaces and public areas smoke-free, running large public awareness campaigns about the dangers, banning tobacco advertising, all proven strategies.
And these are cost effective.
Very. The cost of implementing these is estimated to be less than 50 cents per person per capita, and where they've been put in place properly, they've worked. We see measurable reductions in smoking.
That seems like a bargain for the potential health gains.
It really is. However, a key challenge is implementation and political will. Only about 180 countries have actually ratified the WHO Framework Convention on Tobacco Control, which outlines many of these essential steps.
Still a ways to go on global adoption, though.
Definitely. But the data shows that countries that did implement these measures saw a significant decrease, about 1.57% reduction in tobacco use prevalence per measure implemented between 2007 and 2014. So the more you do, the better the results.
Clear evidence. What about strategies for managing diabetes and improving overall heart health globally?
Yeah, similarly, there are several evidence-based and cost-effective ways to manage diabetes, which Rutherford actually covers in another chapter. More broadly, strategies to improve cardiovascular health around the world can be kind of grouped into three levels. Policy changes at the government level,
Okay.
interventions at the healthcare provider level, so what doctors and nurses do,
Right.
and actions aimed at patients themselves, like education and support.
A multi-pronged approach.
Exactly. For example, something relatively simple like primary prevention using aspirin, a statin for cholesterol, and blood pressure lowering medication in individuals who are identified as being at high risk.
Like a polypill concept.
Sort of, or just ensuring those components are addressed. This can significantly reduce their risk of death for a relatively low cost, particularly in lower income countries, maybe less than $1 per person in low income settings, less than $3 in middle income.
That's incredibly affordable.
It is. And this type of preventative treatment in high-risk patients, say between 40 and 70 years old, is estimated to prevent around 20% of cardiovascular deaths over a 10-year period. Huge potential impact.
20%. That's substantial. Okay, that gives us a really helpful overview of the international situation. Now let's bring it closer to home and turn our attention to ethnic trends, focusing mainly on the United States. We know the U.S. population is becoming much more diverse. What are the projections for these demographic shifts looking like?
Yeah, the current trends in the U.S. population show really significant changes coming in the proportions of different racial and ethnic groups. Compared to, say, the year 2000, the percentage of white individuals is projected to decrease noticeably,
Okay.
while the percentages of Hispanic and Asian individuals are expected to nearly double by the year 2050.
Double. Those are really significant shifts in the makeup of the country.
Absolutely. Those are substantial changes.
So how are these evolving demographics interacting with or affecting the risks for cardiovascular disease within different ethnic groups?
Well, what's really important to understand first is that the racial and ethnic categories we often use, they're very broad, right? They encompass groups with a huge amount of genetic diversity within them.
Sure, they're social constructs as much as anything.
Exactly. And research strongly suggests that social and environmental factors, things like psychosocial stress, nutrition, and especially differences in how healthcare is accessed and delivered these, actually have a more powerful effect on vascular disease trends within these groups than genetic factors alone.
So environment and access trump genetics, largely.
In many cases, it seems that way for these broad trends, and we definitely observe notable differences in the prevalence of key cardiovascular risk factors like obesity, diabetes, high blood pressure, high cholesterol, and smoking across these groups in the U.S.
Okay, let's break down some of those key risk factors by ethnicity in the U.S., maybe starting with obesity.
Okay, obesity. Using the standard definition, a BMI of 30 or higher. The rates are highest among non-Hispanic Black adults, at nearly 50%.
Wow, almost half.
Followed by Hispanic adults at about 45%, and then non-Hispanic white adults at around 42%. Asian adults in the U.S. have a much, much lower rates of obesity, around 17%.
Big differences there. What about how common diabetes is across different ethnic groups in the U.S.?
Well, the percentage of adults diagnosed with diabetes, after you account for age differences, has actually increased at a pretty similar rate across all racial and ethnic groups in the U.S. over time.
Okay, so everyone's seeing an increase.
Yes, but there's a caveat. It's possible that the rates for Asian individuals are actually underestimated in some surveys.
Why is that?
Because the BMI level that signals increased risk for diabetes and related conditions is generally considered lower for people of Asian descent compared to other groups.
Ah, so the standard cutoff might miss people.
Potentially. In fact, when you adjust for age, gender, and BMI differences, some studies show Asian adults in the U.S. are about 60% more likely to have diabetes than white adults.
60% more likely, even with lower obesity rates overall? That's significant.
It really is. It points to different underlying physiologies or risk profiles.
Right. Okay, how does the prevalence of high blood pressure, hypertension differ across ethnic groups in the U.S.?
Looking at data from the big national surveys, NADS, the percentage of adults with high blood pressure adjusted for age increased quite significantly between the late 80s, early 90s, and the early 2000s.
Okay, an overall rise.
Yes, and the highest rates were consistently seen among Black adults, while the lowest were generally among Hispanic adults. This pattern basically continued into the late 2010s as well.
And what's driving that rise?
A lot of it seems to be linked to increases in BMI, especially for men. It explains a large part of the rise in men and a significant portion of the increase in women, too.
Obesity strikes again.
It does. We've seen the biggest relative increases in prevalence among white and Black women specifically.
Okay. What about awareness and control of hypertension?
This is where some interesting disparities appear. Among white adults, awareness, treatment, and actually getting blood pressure under control improved significantly for men over time, but not as much for women. Black adults consistently had the highest rates of awareness and treatment in the surveys, with significant improvements over time, too, which is good.
Okay.
But the rates of actually achieving blood pressure control have consistently lagged behind white adults.
So aware and treated, but not controlled as effectively.
Often, yes. And Hispanic adults have consistently shown the lowest rates of awareness, treatment, and control. And unfortunately, that gap, that disparity, hasn't really shown much improvement over time looking back from the late 80s to around 2012.
That's concerning, that lack of progress for Hispanic adults. What about high cholesterol levels, hypercholesterolemia in different ethnic groups in the U.S.?
Well, data from NADAs between roughly 1999 and 2016 didn't show significant changes in the differences in high cholesterol prevalence among white, Black, and Hispanic adults during that period. Things were relatively stable in terms of the gaps.
Okay, and what were those prevalence rates like?
The age-adjusted prevalence was highest for white adults, around 13%, but actually quite similar for Hispanic adults, 11.2%, Asian adults, 10.8%, and Black adults, 10.5%.
So the actual rates aren't hugely different, unlike hypertension.
The prevalence rates are closer, yes. However, there are still significant disparities when it comes to management.
Oh, so?
Black and Hispanic adults are less likely than white adults to report having had their cholesterol checked. And even if their lab values show high cholesterol, they're less likely to be told by a healthcare provider that they have high cholesterol.
Whoa, a communication gap. Or access.
It could be a mix of things, but the downstream effect is lower rates of treatment and control in Black and Hispanic populations compared to white adults.
But if they are told,
Interestingly, once they are told they have high cholesterol, people from all three groups, white, Black, Hispanic, are equally likely to use cholesterol-lowering medication. So the barrier seems to be more upstream in diagnosis and communication.
that's a really key finding. Okay, and finally, when it comes to these traditional risk factors, what are the ethnic trends in smoking in the U.S.?
Well, overall, cigarette smoking has declined among U.S. adults generally, which is good news.
Right.
But it remains quite common, disproportionately high, among American Indian and Alaska Native adults, around 23% in recent surveys.
Much higher than other groups.
Significantly. Black and white adults tend to show similar rates of smoking and also similar rates of decline over time.
Okay.
Now, despite some research suggesting that Hispanic smokers might be less likely than white smokers to receive advice or help from a doctor to quit,
Uh-huh.
Hispanic and Asian adults have actually shown the largest reductions in smoking rates by racial ethnic group over time.
Oh, interesting. So maybe less reported intervention, but greater reduction anyway?
It seems that way, yeah. Perhaps cultural factors or community initiatives are playing a role there. It warrants more investigation.
Definitely. Okay, let's move from these broad risk factors now to specific vascular diseases and how they affect different ethnic groups in the U.S. Maybe start with stroke again.
Okay, stroke. As we know, it's a major health concern in the U.S., and the age-adjusted prevalence, how common it is highest among Black adults compared to Hispanic and white adults.
Higher prevalence in Black Americans.
Yes. There's also quite a bit of evidence suggesting that racial and ethnic minority groups are generally less likely to receive certain surgical and non-surgical treatments for stroke, and unfortunately, they also tend to have worse outcomes after these treatments.
Can you give some examples?
Sure. For instance, Black Americans who have an acute ischemic stroke, the most common type, are less likely to be admitted to specialized stroke centers of excellence.
Okay.
The use of a critical procedure called mechanical thrombectomy, which removes the clot, is also less common among Black and Hispanic adults compared to white adults who are eligible for it.
So less access to specialized centers and key interventions.
It appears so. And the difference in treatment for severe narrowing of the carotid artery, a major stroke risk factor with the surgery called carotid endarterectomy, that disparity seems most pronounced for Asian adults compared to white adults. They have lower rates of receiving that surgery.
Are these differences in treatment solely down to differences in access to health care, like insurance or geography?
Access definitely plays a significant role. There was an interesting set of studies done within the Veterans Affairs healthcare system, the VA.
Okay.
The VA system aims to provide equal access to care for all eligible veterans. And within that system, studies didn't find significant racial disparities in the rates of carotid endarterectomy.
So when access is theoretically equalized, that specific disparity disappeared.
In that context, yes. It strongly suggests access is a major driver for that particular procedure. However, the story gets more complicated when you look at outcomes. Negative outcomes after carotid endarterectomy, like having a stroke during or shortly after surgery or even death, have been reported to disproportionately affect Black and Hispanic adults. They tend to have higher rates of these complications compared to white adults in some studies.
Even if they get the surgery, the outcome might be worse. Why would that be?
Well, limited access to the best surgical care might be a contributing factor. It's not just about getting the surgery, but where you get it and who does it.
Right. Experience matters.
Exactly. Analysis of a large registry of vascular procedures showed that Black patients were more likely to be operated on by surgeons who perform fewer of these procedures or in hospitals that do fewer of them, overall lower volume providers and centers.
Okay.
And importantly, when these factors, surgeon volume, hospital volume, were taken into account statistically, the difference in postoperative stroke or death rates between Black and white patients was no longer significant.
So it wasn't race itself, but the experience level of the care they received.
That seems to be a major component, yes. It points towards systemic issues in where patients receive care.
That's a crucial distinction. Okay, what about ethnic trends in peripheral arterial disease, PAD, in the U.S.?
Right, PAD. Again, we see disparities. The prevalence of PAD in the U.S. is highest among Black adults, followed by white, then Hispanic, and then Asian adults having the lowest prevalence.
Highest in Black Americans again.
Yes, and among individuals who have both diabetes and PAD, the rate at which PAD is diagnosed has actually increased faster for Black adults than for white adults over time.
So a faster rise in diagnosis among Black diabetics.
Correct. We also see differences in treatment approaches. More white patients who experience claudication, that leg pain from poor circulation,
Okay.
are treated with endovascular procedures, those less invasive techniques done inside the blood vessels compared to Black and Hispanic patients with similar symptoms.
Fewer minimally invasive procedures for minority patients. What about outcomes after procedures?
Well, the rates of death and major complications in the immediate short term, say 30 days after PAD procedures, seem to be pretty similar across groups.
Okay, that's good.
But a higher rate of early failure of grafts used in bypass surgery has been observed among Black and Hispanic patients.
So the bypasses don't last as long.
They seem to fail earlier, yes. Also, how well the treated arteries stay open over the medium to longer term, what we call patency, that is markedly inferior in Black patients specifically.
Why would that be?
It might suggest that Black patients have a more aggressive biological process of tissue growth inside the blood vessels after intervention, something called neointimal hyperplasia, which can lead to reblockages more quickly.
A potential biological difference in healing or response.
It's a possibility that's being investigated alongside other factors, of course.
Okay. And what about the really serious outcome of PA that we discussed earlier? Amputation.
This is where the differences are particularly stark and concerning in the U.S. context. Black and Hispanic Americans with PA have a disproportionately high rate of non-traumatic lower extremity amputations, losing a leg or foot not due to injury.
How much higher?
2 to 4 times higher than white Americans with PA.
2 to 4 times higher. That's a massive disparity.
It's huge. And this higher rate in minority populations persists even when you statistically control for factors like other risk factors for atherosclerosis, how severe their PAD is, rates of infection, and even income levels.
So it's not just explained by worse disease or poverty.
It doesn't seem to be fully explained by those factors alone, no. It suggests other things are going on.
It's like what? What are the potential reasons?
Well, it might be due to the disease being diagnosed at a later, more advanced stage in minority patients. There could be differences in awareness of PAD symptoms, both among patients and maybe even providers. Differences in how PAD is medically managed before it gets severe. And crucially, differences in access to timely specialized care, including revascularization procedures aimed at saving the limb.
Can you elaborate on the medical management and access points?
Sure. For example, studies have shown Black patients with PA are less likely to be prescribed or treated with statins compared to white patients with PA.
Even though statins are crucial.
Absolutely. And a smaller percentage of Black patients with diabetes report receiving recommendations from their doctor to take aspirin for prevention compared to white diabetic patients.
Gaps in basic preventative care.
Seems like it. There's also evidence suggesting that Black patients with PAD may receive less aggressive treatment overall with limb-saving procedures like lower extremity bypass surgery and endovascular interventions.
So maybe a bias towards amputation or less offering of complex salvage procedures.
The data confirms that Black and Hispanic adults are significantly less likely to undergo these revascularization procedures, either open bypass or endovascular, than white adults, even when you control for various clinical and demographic factors.
Wow.
And even among Medicare patients who eventually did have an amputation, Black individuals in that group were less likely to have had a revascularization procedure attempted before the amputation compared to white amputees.
So less likely to have even had an attempt to save the limb beforehand. Is there any evidence that Black patients are less willing to try limb salvage? Maybe they prefer amputation?
No, there's actually no evidence to suggest that Black patients are less inclined to want to attempt limb salvage. Patient preference doesn't seem to explain this disparity.
Okay, so what else could be contributing to these stark differences in PA outcomes and amputation rates?
Well, as we touched on, socioeconomic factors are likely involved. Higher rates of poverty and lower rates of health insurance coverage in many Black and Hispanic communities can definitely impact the treatment options people have access to or feel they can pursue.
Yeah, cost and insurance are huge barriers.
They are. Minorities are also often disproportionately treated in safety net hospitals, which do vital work but might be under-resourced or have providers who are incredibly overextended.
Right.
There's also data showing that in procedures performed on Black patients, surgical residents doctors still in training are more often involved. which, while necessary for training, could potentially contribute to variations in outcomes or complications in some complex cases.
The training environment factor.
And being underinsured or uninsured can lead to significant gaps in crucial follow-up care after procedures, which is vital for maintaining limb salvage. If you can't afford follow-up visits or medications, the initial success might not last.
It sounds like a complex web of interconnected factors, socioeconomic, systemic, provider level, access, all contributing to these terrible disparities in paid outcomes.
Absolutely. It's rarely just one thing. It's a multi-layered problem.
Okay, let's turn to trends in aortic aneurysm in the U.S. across different ethnic groups. What do we see there?
Right, aortic aneurysms. Population studies generally indicate that aneurysms, both abdominal and thoracic, are actually more common overall among white adults compared to Hispanic and Black adults in the U.S.
Oh, okay, so higher prevalence in whites for this condition.
Generally, yes. However, even when you account for that difference in prevalence, there are still disparities in care. Black and Hispanic patients who do have aneurysms are less likely to undergo planned elective repair,
Okay.
and they are significantly more likely to present to the hospital emergently with a ruptured aneurysm, which is often fatal compared to white patients.
Less selective repair, more emergency rupture. Why might that be?
It might be linked back to less consistent access to regular primary care, where screening might occur or symptoms might be picked up earlier, and potentially lower rates of screening for aneurysms, specifically in minority communities. They might just not be getting diagnosed until it's too late.
Access and screening again.
Yes. And similar to the PAD situation, Black and Hispanic individuals are also more likely to receive aneurysm treatment at hospitals that do fewer aneurysm repairs, overall low-volume facilities, and also more likely to be treated by surgeons who don't specialize in vascular surgery.
Lower volume, less specialized care potentially. And does this impact outcomes?
Unfortunately, yes. Several studies have shown higher rates of complications, illness, and death after both elective, planned, and emergency endovascular aneurysm repair, the less invasive EVIR procedure among Black and Hispanic patients compared to white patients.
Higher mortality, even with the minimally invasive approach.
Yes, even after statistically controlling for various patient-related factors like how sick they were and hospital-related factors like volume.
Wow.
And it's not just EVAR. Black individuals also have a higher risk of death during or shortly after the traditional open surgical repair of thoracic or chest aneurysms compared to white individuals, even when you adjust for the hospital's experience with those complex surgeries.
Consistent disparities across different types of aneurysm repair. Is there any area where outcomes are more equal?
Interestingly, there's one specific finding. Black, Hispanic, and Native American populations are actually more likely to undergo thoracic endovascular aortic repair, TVAR, compared to white individuals.
More likely to get TVAR.
Yes. And for this specific procedure, TVAR, there don't appear to be significant racial or ethnic differences in complication rates or death rates reported in the current literature.
Huh. That's one exception then. Any idea why that might be?
It's not entirely clear. It could be related to patient selection, specific hospital protocols for TVAR, or maybe the nature of the procedure itself leads to more standardized outcomes across different settings. It's an area that probably needs more research.
Okay. Finally, let's briefly touch on hemodialysis access and any ethnic differences we see there as it relates to vascular health.
Right. This is crucial because of kidney disease disparities. Black adults in the U.S. have a significantly higher incidence, meaning new cases, of end-stage kidney disease, ESRD, requiring dialysis over 3 times the rate compared to white adults.
3 times higher ESRD rate. Is that genetic?
There is known to be a genetic component contributing to this, specifically certain variations in a gene called APO1, which are much more common in people of West African ancestry.
Okay, so genetics plays a role.
It does. However, even among Black individuals who don't have these specific high-risk APO1 gene variants, their risk of chronic kidney disease progressing to ESRD is still higher than in white individuals.
So genetics isn't the whole story there either.
No, it suggests other factors are also significantly at play, potentially differences in managing underlying conditions like hypertension and diabetes, socioeconomic factors, environmental exposures, and again, access to care.
Access seems key for kidney disease too.
Absolutely. Limited access to kidney specialists, nephrologists, and just generally lacking adequate health insurance may explain why Black and Hispanic patients who have chronic kidney disease are less likely to receive care from a nephrologist before their kidneys fail completely compared to white patients.
So they arrive at ESRD potentially less prepared.
Exactly. And this has direct consequences for dialysis access because they often haven't had that specialist care leading up to dialysis. White patients have a significantly greater chance of starting hemodialysis using the preferred type of vascular access, which is an arteriovenous fistula, an AV
Which
fistula.
generally works better and lasts longer, right?
Correct. Black and Hispanic patients are more likely to start dialysis with less optimal access, like central venous catheters, which have higher risks of infection and complications.
So the disparities in kidney care lead directly to disparities in the quality of their dialysis access.
Precisely. It's another example of how upstream factors cascade down to affect vascular outcomes.
These are really significant, deeply entrenched disparities across so many aspects of vascular disease in the U.S. It's quite sobering. What are some of the ways we can even begin to address these inequities? It seems like such a huge challenge.
It is a huge challenge, and addressing these disparities requires a really comprehensive, multi-level approach.
Hmm.
You have to target the healthcare systems themselves, healthcare providers, and patients, too.
Okay, let's break that down. What about at the systems level?
Well, many argue that the way healthcare systems are structured and regulated is actually a primary source of these disparities. So, policies at the federal, state, and even individual hospital or institutional levels should actively aim to change the culture within healthcare facilities to promote equity.
Culture change from the top down.
Yes, and practical things matter too. For example, expanding access to comprehensive healthcare coverage has been shown to reduce disparities. We saw evidence of this in Massachusetts after they implemented their health insurance expansion. Access matters.
Makes sense. What about at the provider level? What can doctors, nurses, and other clinicians do?
This is critical. Unconscious bias, or even just uncertainty when communicating with patients from different backgrounds, can be major sources of disparity in clinical decision-making.
The implicit bias factor.
Exactly. So, healthcare providers need ongoing training and self-reflection to develop cultural competency and humility. We all use cognitive shortcuts mentally, but we need to be aware of how they can introduce bias into our clinical judgments.
Awareness is the first step.
Absolutely. And adhering strictly to evidence-based clinical guidelines for all patients, regardless of background, can help standardize care. Using things like electronic health record tracking and reminder systems specifically for recommended care for minority patients can also help ensure things don't fall through the cracks.
Using technology to promote equity.
Yes. And having clear, standardized protocols for when to refer patients to specialists can help address those referral disparities we talked about earlier.
Okay. And finally, what about at the patient level? What can be done there?
Educational programs are important, designed to improve patients' awareness of vascular diseases, their own risk factors, and how to navigate the healthcare system more effectively. Empowering patients with knowledge.
Patient engagement.
Exactly. It's also important to recognize that sometimes patients from minority groups may be less communicative or feel less comfortable asking questions, particularly if their provider is from a different racial or ethnic background. Building trust is key.
The importance of rapport.
Huge. And related to that, increasing the representation of minorities within the healthcare workforce itself may facilitate better communication, trust, and ultimately treatment uptake and adherence.
Seeing providers who look like you can make a difference.
Research suggests it often does. Also, improving patients' knowledge about specialized services available at high-volume centers, the ones with better outcomes, and actively addressing any barriers they might face in accessing those centers, like transportation, childcare, time off work, that could also help reduce some of the outcome disparities we see, especially for complex procedures.
Addressing those practical barriers to accessing the best care.
Exactly. It has to be a multifaceted effort.
Wow. This has been an incredibly insightful and, frankly, quite comprehensive deep dive into both the international and the ethnic trends in vascular disease. A lot to take in. To try and bring it all together, what are maybe one or two of the most important takeaways that you'd really like our listeners to keep in mind from this discussion?
That's tough. There's so much. But I think two really critical points stand out for me. First, just the sheer scale of the global diabetes epidemic. That rapidly increasing number of people with diabetes worldwide is a major driving force behind the growing burden of vascular disease everywhere. And this trend, sadly, is expected to continue with really significant differences across different regions that we need to watch.
Right, the diabetes wave is huge and global. What's the second point?
The second, focusing on the U.S., is the starkness of the amputation disparity for payee, those disproportionately high rates of lower limb amputations among Black Americans. Specifically, even when you try to account for other risk factors, it just serves as a really powerful and sobering reminder of the persistent and complex inequities that still exist in vascular health outcomes right here.
Yeah, that amputation statistic is incredibly jarring. It absolutely highlights how interconnected everything is. Risk factors, yes, but also access to quality care, systemic biases, broader societal issues, all shaping vascular health both around the world and within our own communities.
Precisely.
So thinking about these disparities and the multi-level solutions you mentioned, what role do you believe individual actions, things we can do ourselves versus community-based initiatives versus broader changes in policy, what role can they all play in trying to create a more just and equitable landscape for vascular health for everyone, everywhere?
That's really the million-dollar question, isn't it? And it's a question for all of us to ponder: patients, providers, policymakers, citizens. How do we collectively move the needle? For listeners interested in digging deeper, you might find it valuable to explore the work of organizations that are specifically focused on global health equity, or those researching the impact of social determinants, those non-medical factors like poverty, education, environment on health outcomes. That's where a lot of the answers likely lie.